Welcome, everyone, and thank you so much for joining us today. My name is Lindsay Goldman, and I am the CEO of Grantmakers in Aging. Grantmakers in Aging is a national membership organization that serves as a network and resource for funders and a champion for aging-related issues and investments. With over 100 members, GIA works to mobilize the social, intellectual, and financial capital required to improve the experience of aging now and in the future. Today's webinar is hosted in partnership with the Serious Illness and End-of-Life Funders community, a network of over 30 funders with a shared commitment to improving the care of people with serious illness and their caregivers. We'd also like to thank the John A. Hartford Foundation for sponsoring our Conversations with GIA webinar series. Today, we will share an exciting body of work to build empathetic, trusting relationships when communicating with people with serious illness through telehealth. Joining us today, we have Peggy McGuire, President of Cambia Health Foundation and Governance Chair of GIA's Board of Directors, Rachel Watman, Vice President of Programs at the Rita and Alex Hillman Foundation, a member and longtime supporter of the Serious Illness and End-of-Life Funders community. Adriana Glenn, Assistant Professor of Nursing at the George Washington University School of Nursing. Elizabeth Anderson, Assistant Professor of Social Work, at Western Carolina University. Joanne Stevelos, Executive Director of the Coalition for Supportive Care of Kidney Patients at the School of Nursing at George Washington University, and Dr. Dale Lupu, Executive Committee Advisor at the Coalition for Supportive Care of Kidney Patients at GW. Thank you all for being here today. We will be recording today's session, and in the next few days, you'll receive an email with the webinar recording along with the presentation slides. We will have a Q&A portion following our panel presentation, so please submit your questions at any time using the question box in your control panel. Joanne, I will now turn things over to you.
Thank you, Lindsay. Thank you, Lindsay. We so appreciate this opportunity to join this conversation, and we also appreciate the support that you've given us to make this presentation possible. My name is Joanne Stevelos. I'm the Executive Director of the Coalition for Supportive Care of Kidney Patients, and we sit in the George Washington University School of Nursing. Next slide, please. At the Coalition of Supportive Care of Kidney Patients, we have over 800 members currently. Part of our membership are large dialysis organizations, clinicians, patients, people from the healthcare industry. What we really want to emphasize in our supportive care work is that we are really working in a space that's under-resourced and overburdened in our current healthcare framework. And we're working with populations where people are not giving the treatment options and the supportive care options that many other types of diseases have available to them. For example, one of the ways we think about supportive care of kidney patients is that we're about 40 years behind the care that cancer patients receive. So there's a lot of work that we're doing at the Coalition to improve the conditions of the care and the quality of life for kidney patients and their caregivers. We really are working hard to promote the effective interchange among patients, families, and healthcare professionals and payers to ensure that what people are receiving patient-centered supportive care treatment options. And really, I think one of our strengths at the Coalition is that we're really trying to create a culture change that transforms the care for people. And we're trying to reach out through our educational programs, through resources we've developed, which you'll hear about later in this presentation. And we are working to with continuing medical education opportunities so that our healthcare teams are trained in evidence-based practices. And I'm going to hand this over to Dr. Dale Lupu, who's going to share a little bit more about supportive care and some of the evidence-based practices that have come out of our work. Next slide, please.
Thank you, Joanne. So just these are some of the advisors that work with us at the executive committee. And let's go to the next slide. So as Joanne said, what we're trying to do is bring together the voices and support each other in bringing, oops, start my video. Now you guys can see me shortly. In kidney care, there's not so many people who have paid attention to, done the work, done the research to look at how do we bring what the rest of the world calls palliative care, but in kidney care, we like to call it supportive care because that's the term the patients have told us that they prefer. So we're trying to empower the people who are interested in the population of people with kidney disease, give them the support that, yes, this is an important thing to pay attention to. And then in the palliative care world, to help them understand what do they need to do to reach this patient population, to work with providers in dialysis organizations, in kidney care clinics, because they don't have the skills built to do that. Let's go to the next slide. So what are some opportunities? We've had wonderful support, especially from the Gordon and Betty Moore Foundation. You'll hear from the work from the Cambia and Hillman Foundation today. But there are lots of opportunities to work together to advance this field. We're looking for partners who will collaborate with us on research, on developing more toolkits and education so that we can bring the evidence directly to providers. We'd like to engage more patients in helping us in developing and reaching other patients, so more engagement directly with patients. And we would like to do more policy work. We had an interesting conversation with CMS just this week, who says that they want this to bubble up from the field, that they are reluctant to put forward these needs directly or to mandate that dialysis providers work on serious illness care. They want to see that developing from the field itself. We want to see it develop from the field, and we would welcome other partners to help us do that. I won't go, we have lots of ideas of what needs to be done, and I think it's enough said now, and I will, I think, turn it back so that you can hear from our wonderful researchers who have advanced their two projects during this time of COVID.
Hi, I'm Peggy McGuire. I'm the president of the Cambia Health Foundation. And if you go to the Cambia slides, please. Or am I going out of turn?
No. I thought I was only supposed to take a few minutes, and all these slides are available from Grantmakers in Aging if people would like them, but we wanted to give you the time.
Okay, great. Well, here we go. These are my slides. Hello, everyone. I'm Peggy McGuire. I'm the president of the Cambia Health Foundation. And as Lindsay said, I also have the honor of serving on the Grantmakers in Aging board. I've been asked to tell you a little bit about the Cambia Health Foundation and why we chose to support the work that you'll be hearing about today. Cambia is based in Portland, Oregon, and we're the corporate foundation of Cambia Health Solutions. We were founded in 2007 as a way for our parent company to be more strategic and impactful with its philanthropy. So our foundation is actually a separate 501c3 grant-making organization that is entirely funded by our parent company. And we share the same cause as our parent company, which is to serve as a catalyst to transform healthcare to be more person-focused, equitable, and economically sustainable. Please go to the next slide. We do our work through four pillars: strategic grant making, convening and thought leadership, raising awareness and engaging our 5,000 employees in philanthropy, and then being a responsible steward of the funds that are entrusted to us. And the next slide, please. 15 years ago, we made a strategic decision to invest in palliative care because we viewed it as an expression of our person-focused cause. We believe it's the type of care that a person should expect throughout one's journey with the healthcare system. It's really focused on what matters to people instead of what's the matter with them. At the time that we began funding in palliative care, it was not a well-known medical specialty, and we believe that philanthropy could have an impact on growing the field. And we hope that by advancing this type of person-focused whole person care for a segment of the population, it would serve as a broader catalyst to transformation, really focused on a healthcare system that hones in on people and makes healthcare easier for them and their lives better. Since 2007, the foundation has invested more than $48 million to advance access, awareness, and quality of palliative care across the country, including $15 million toward our Sojourn Scholar Leadership Program. Please go to the next slide. This is a map of where our Sojourn Scholars exist and work. This program began in 2014 because we really felt like our ability to identify, cultivate, and advance the next generation of palliative care leaders would not only improve the care of people with serious illness and support their loved ones, but it would ultimately serve as a catalyst to whole person healthcare. And you'll hear from one of our scholars, Dr. Liz Anderson, so proud of the work that she's doing. Liz was one of the first social workers to join the Scholars Program, and she has continued to grow as a leader in the field. Her project with us during the Scholars Program was really to engage family members of patients with kidney disease in rural areas to ensure that patients would receive high quality, person-focused palliative care that was consistent with their personal goals and values. And Liz's work led the way to develop a best practice tool for providers of patients in kidney disease with kidney disease living in rural communities, really to support them and their families. Her leadership and her work is now being leveraged through the Rita and Alex Hillman Foundation. I know on our team, we are big fans of Rachel Wattman, who you'll be hearing from in a minute. And we are so excited that the Hillman Foundation has joined us in supporting this important work. And, just a little bit, Lindsay mentioned the funder collaboratives at the beginning of the call. We are an active member, our foundation is an active member of those collaboratives. And, we are so honored to work with and collaborate with the Hillman Foundation and the John A. Hartford Foundation and others. These collaboratives give us an opportunity to network and learn from other foundations, and then really to accelerate and amplify the work through collaboration. So please go to the next slide. I want to have a little word about technology here, because I think in our world today, technology is more important than ever. It's a connector and enabler. It supports healthy and connected aging. It allows, telehealth specifically allows providers to extend their reach into rural communities And telehealth is often more convenient for people, especially people living with serious illness and their caregivers who may find it difficult to get to and from appointments. So telehealth is here to stay, and which is wonderful. But I do want to caution us that technology cannot replace the human touch. And I also want to remind us that not all people live in communities that are supported by broadband or that have access to technology. And so as we move forward, I just want to encourage us all to focus on the people that we serve, developing solutions that work for people, keeping people at the center, but also focusing on equity and the equitable deployment of new solutions. I don't need to say this, but we'll go to the next slide. During the pandemic, I think the gaps and inequities in our healthcare system were just exacerbated and spotlighted. And during that time, our foundation team took a step back and said, what is the way that we can best deploy our resources in a world that's been forever changed by COVID? And we came up with putting equity right at the center of our plan. So equity used to be the desired outcome of our work. And now we're thinking it is our work to think about advancing equity through whole person health in underserved communities. That's our vision for what we will be doing over the next 10 years. And that's really connecting physical health, social determinants of health, and behavioral health, which is an incredible need in our communities right now. And so we are going to focus our grant making in 3 areas. One is maybe not so relevant to this group, but it's resilient children and families and birth equity. We start to age the minute we're born. And so to set people on a healthy trajectory throughout the lifespan, we want to focus on that birth equity piece. Then healthy and connected aging. We know the pandemic has had an incredible impact on the well-being of people who are experiencing loneliness and isolation as a result of the pandemic. And we want to find ways to use technology to integrate behavioral health into primary care and also to help people connect with one another. The last area of focus for us is the healthcare workforce. And in this workforce, we include both the paid and the unpaid caregivers, thinking about, as more and more care is moved into the home and we expect more of patients and families, how do we as philanthropists support their commitments and their work? So I want to just end here by saying thank you. We look forward to collaborating with the Hillman Foundation and the John A. Hartford Foundation and other funders as we roll out this vision. For today, I want to thank GIA for hosting this important conversation, and thank you all for joining us. Now I'll turn it over to Liz Anderson. Liz?
All right. Hello. And again, thank you all so much for having us here today. I am super lucky to be able to work with the Coalition of Supportive Care Kidney Patients, which is how I actually found out about the Sojourns program, and am now excited to be learning more about the Hillman Foundation as well. My background, sort of how did we get to this need to convey empathy in telehealth? As part of the Sojourns program, I got funded in 2018 and started my project in 2019, the year before COVID, as you all will remember. And I had done all of these interviews with patients, providers, caregivers, about rural palliative care and how do we talk about that? And the one thing that I kept hearing over and over again is A, we want to talk about this, and B, when we talk about this, we need people to show their care and concern. And I dug into that and I was like, well, how? Like, how does one show care and concern? Because we're so fixated in the medical community with educating. Like, how do we show care and concern so that people can hear us? And when I interviewed these folks, they talked a lot about like how we as providers can show our body language and our tone. And they showed me gestures, etc. And I simultaneously was doing another project or analyzing some data about massage and palliative care. And I was thinking about all of this when March 2020 hit and we had this pandemic and all of a sudden this movement to telehealth. And as part of my work with the coalition, we were doing these open office hours, and we had invited dialysis and transplant facility staff to just be able to have a debrief in the early ages of COVID. And Dale and I and Woody Moss facilitated those. And we kept hearing from people just how awful it was to experience all of this death and dying with patients with kidney disease who were significantly more impacted by COVID. And to not be able to like be face-to-face with them and to be using telehealth sometimes for the first time with folks, or if they were face-to-face, they were masked up and in their, more than in their scrubs in those situations. And we really just heard, as I'm sure you all know, all of these healthcare providers really in like moral distress about how to handle this. It was such a new area for them. And so that led me to this question of like, how are we going to show up the way that patients and caregivers have told me we have to show up for these conversations in telehealth? Next slide. So fortunately, Cambia was really flexible with our projects and actually invited us to consider how we could shift gears to address this. And so I made a pivot and we did a literature review about telehealth, which was really fascinating in 2020 because almost everything we found about telehealth and end-of-life care pertained to ethics and legal information, but it wasn't about how do we show up as human beings and have really difficult conversations with people. And so we did 10 interviews with patients, caregivers, and providers about, how do you show up? Like if you're going to have a serious conversation via telehealth, what are the skills that are necessary in order to have that? And then we analyze that data. So next slide. And so we found all kinds of different things that are probably not that surprising to you all. There are significant impacts for people with kidney disease, and there were a lot of challenges, right? Like we heard from providers, there were a lot of challenges in terms of just, prognostics and assessing symptoms, but we did hear a lot from providers, patients, and caregivers about the challenges to physical touch, body language, and building relationship over telehealth. And again, I took this opportunity to be like, well, what do you do? Like, how can we make that better? And at the end of the day, what we really heard was using empathetic language, both verbal and nonverbal, are really, as we say in another project, it's the fuel that we need to get the car to go, right? We have to have that piece in order to have serious conversations. Next slide. And so we developed a guide for providers. We actually developed a guide for providers. We developed a guide for patients, and we developed a webinar in which we actually did role plays and all kinds of stuff. But the 7 things that really came up are listed here that we go through in the guide one by one in a lot more detail. And so, building empathy, building relationship, lots of stuff about nonverbal communication, but also how do we communicate with our team members? How do we acknowledge our own bias? And as you all know, this was all happening also in the middle of the murders of Breonna Taylor and George Floyd, and all of this was coming up. Like, how do we talk about those things? Because they're coming up for people too in telehealth environments. How do we conduct our visits? And how do we really support the workforce, which is what number 7 is. And I think, what really came up was this acknowledgement that physical touch and body language is a means to solve our sympathetic and parasympathetic systems when we get upset. And oftentimes conversations, if not handled with empathy, can do that. And, I remember one of the people that we interviewed said, I just keep thinking about, after the World Trade Center happened and the images of people on top of the World Trade Center that didn't know each other, holding hands before they jumped, and that physical touch, like how important that is. And I think we can see that even in the news from this week. When we look at shootings that happened in school, we see that physical touch shows up as a means to support people. And so how do we do that in telehealth? We do that lots of different ways. This is what we heard from people. We sit down, like literally sit, stop, give eye contact. And we heard a lot about needing to give silence in telehealth and how challenging that is. We heard people talk about how if you can't touch people, you can verbalize your desire to do that. And so saying, if I were here with you right now, I'd want to give you a hug. And so the guide really encompasses a lot of those principles that we learned from our interviews in terms of, how do we really, how do we have these conversations in such a way? Next slide. So now that that's out and we're disseminating that in the dialysis community, what do we need next? Like what else is to come? And so through these conversations, we're like, well, A, it would be great if we could test this guide. And B, it would be really important if we could culturally tailor it to different groups, understanding that communications patterns vary so much. And so I was super excited. I already was working with Adriana Glenn in another project with the coalition, the My Way project. And she has beautifully taken this guide to that level. So I'm going to pass it now to Rachel at Hillman, who's going to talk a bit about that.
Thank you, Liz. So hi, I'm Rachel Watman. I'm the Vice President of Programs at the Rita and Alex Hillman Foundation. And for the next 5 minutes, I want to share a little bit about the Hillman Foundation, specifically who we are and how we make strategic grants that represent some of the most pressing needs in our society. And I share this with you as a context for why and how we support innovative leaders like our speakers today, including Dr. Adriana Glenn, who will be presenting on her pioneering work regarding empathy after I speak. Next slide, please. So the Hillman Foundation is a national funder. We're located in New York City, and we're committed to improving the health and the healthcare of all people, but especially groups who experience inequity, discrimination, oppression, and indifference. We've been making grants since 1989, and today we're one of the leading philanthropies that are dedicated to advancing health through nursing. Next slide, please. We have a deep concern for social justice and human dignity. We believe that by improving care to communities who experience inequity, we ultimately improve care for all. Next slide. So key to our grant-making approach is this idea of a pipeline for nursing innovation, tailored to different phases in a program's evolution. And you can see this on the slide in front of you. So at the start of our pipeline, on your far left, is our Emergent Innovation Awards. And these awards support early, bold, pre-evidence programs that target health problems in new ways. And I'm going to be speaking a little bit more about this. The one in the middle of our continuum, the expanding program, is our Innovations in Care, which funds evidence-based models of care that are poised for expansion. And then at the far end, the far right of our continuum is our Innovation Dissemination Program, which helps position programs that are ready to scale nationally. And the reason I share this grant-making framework with you is that I want you to see that we as funders are able to solicit ideas directly from the field and to really gain an understanding of urgent issues and healthcare solutions in our society. Next slide. So we're looking for work that fundamentally is three things. We're looking for programs that are nursing driven, that they're really rooted in nursing's unique, holistic, and integrated approach to care. We're looking for programs that are focused on communities who experience inequity, and these include BIPOC populations, economically disadvantaged, LGBTQ people, people who are experiencing homelessness, rural populations, and refugee and immigrant populations. We're also looking for ideas that are innovative, ideas that are bold, creative, disruptive. Next slide, please. And so for the next 2 minutes, I just want to take a deeper dive into our emergent innovation programs. Again, these were these early stage programs that I showed you on the slide before that seek bold early stage interventions that address health challenges faced by marginalized populations, such as the empathy model that Dr. Adriana Glenn is going to be speaking with you about. So we provide $50,000 over 18 to 24 months for untested, innovative ideas who need the funding to build the evidence to launch models of care. And one of the reasons that we created this grant award is because there are far too few funders who invest in pre-evidence work. There's not a lot of funders who give support to researchers to collect the data, to go out and build the evidence. And we believe as funders that this represents a gap in philanthropy. We choose to take a risk on bold ideas and pioneering leaders because we believe that this is essential to seeding the field. And by doing this, it allows us to cultivate a relationship with our grantees. So we encourage, when programs are ready, to apply throughout our grant award pipeline. And that way we have a long-term relationship with our grantees. So as you can see, we have a general emergent innovation award. And then based on the need and the demand from the field, we have one that's tailored specifically to serious illness and end-of-life care. We made our first award in the serious illness program back in 2018. And since that time, we have funded 22 programs that represent all kinds of healthcare settings, from hospitals to academia, to prisons, to community-based organizations. And then in 2021, we were fortunate to begin a partnership with the Arthur Vining Davis Foundations to increase the number of awards. And we are really grateful to the team at Arthur Vining Davis Foundations. We do everything on this work together. And just by way of a plug, we met our colleagues at Arthur Vining Davis through the Serious Illness and End of Life Funders Collaborative that's housed at Grantmakers in Aging. If you're not a member, I encourage you to be on one of our calls. You don't have to be investing in this area. If you want to learn more about it, please be part of our group. Also, as Peggy kindly mentioned, we have jointly supported a number of scholars with partner philanthropies like Cambia, and we know that we do our work better together. Next slide, please. And on this theme of partnership, I'm going to turn it over now to Dr. Adriana Glenn of George Washington University School of Nursing. As I mentioned, Adriana is a 2021 Serious Illness Emergent Innovation Awardee, and her project will establish a culturally tailored approach to help clinicians communicate more effectively with regards to empathy when working with Black patients with kidney disease in a telehealth environment. Dr. Glenn's work not only advances our mission, it aligns with our focus. It's clearly germane to our conversation today. We at Hillman are really proud to invest in Dr. Glenn's work at this early stage, and we look forward to her collection and evaluation of the data to really shape this into an evidence-based model of care to better serve the seriously ill. And with that, I'll turn it over to Dr. Glenn.
Thank you so much, Rachel. So good afternoon, everyone. Thank you, GIA, for having us be able to showcase our work. And so you can see here, my project's entitled A Nurse-Led Approach to Testing and Adapting a Telehealth Guide for E-Empathy and Goals of Care for African-American or Black kidney patients. Next slide, please. So this project is a 12-month project, and it's looking to enhance patient-provider interactions in the virtual space. And it's innovative because it looks at how we can convey empathy some more effectively to Black patients specifically. So with chronic kidney disease, there is not published work in this area. The little bit of information I was able to find shows that in general, telehealth does appear to be promising, but it hasn't been done in this particular population. I want to say a word about empathy. So, empathy is the ability to understand someone else's feelings and thoughts and be able to connect with them, really be able to connect with them, recognize their struggle and acknowledge without minimizing that person's experiences. And so taking the work of Dr. Liz Anderson's guide, which is amazing, I suspected that empathy might look a little bit different in patients that identify as Black or African American. So using a culturally targeting approach, which is basically something that occurs on a larger scale than tailoring, so it warrants designing information for a defined population or subgroup. So in this case, the population is chronic kidney disease patients, and then the subgroup are those people that identify as Black or African American. So I received this generous funding from the Hillman Foundation, which is really critical to even being able to explore this issue. And one of the other major challenges when you are doing work that involves the community, otherwise known as community-based participatory action research, which this project does entail, is that it's difficult to secure funding for that type of research. So I'm immensely grateful for the initiative, for their initiative in this particular area. So basically, moving forward, going to take the general, to better address the care of Black patients with CKD, not as a replacement. So it's not like you see a Black patient and it's like, oh, that's a Black patient, I'm gonna pull out this guide. No, that was not my intent. My intent is you're using this beautifully crafted guide, and if for some reason as a provider, and I am also a provider, I'm also a nurse practitioner. So sometimes you wanna have other things in your toolbox to be able to reach out to someone. So if you had a patient that identified as Black or African American, and you just weren't really, that empathy didn't seem to really be coming through, the provider would have something else in their toolbox. The revised guide will be disseminated by the coalition, which partners with national organizations related to the nephrology community, and that's going to be able to extend the reach. Next slide, please. So what we do know is that we should have individualized conversations with patients to be able to focus on what's important to them and where they see their health, addressing their healthcare issues going. Telehealth is an emerging tool for offering patient-centered care, and it was widely adopted by the kidney care community in order to maintain patient care during the pandemic. And so it's not going away. So while use has maybe dropped a little bit, it's still much higher than it was pre-COVID. Also, we know that implicit bias and perceived discrimination lead to mistrust and poor outcomes in personal care encounters. So it'd be logical to assume that these same factors would impact the telehealth environment, telehealth space as well. However, we don't really know that much about how to mitigate these types of issues in the telehealth environment or how even to recognize them. We also know that CKD is a significant problem in the Black community, where we have, Blacks are making up about 13% of the population, but they're 35% of the patients with the disease. So that's, they're almost 4 times as likely as whites to develop kidney disease. We also know that I mentioned earlier that telehealth does seem to be promising for Black patients in terms of management. And there's been studies in diabetes, which is also another chronic illness that is pretty pervasive in the Black population. And so we also know that when we look at these trends, there is a gap at the convergence of, sensitive telehealth and sensitive palliative care topics or support care topics and Black patient cultural experiences. Next slide, please. So this project is basically rolls out in 3 phases. Phase 1 is currently occurring now, where I'm looking at securing 10 to 15 stakeholders, the advice to comprise an advisory group. So these would be Black patients who are receiving, who have chronic kidney disease, receiving dialysis, their family members, not necessarily related to the patients in the advisory group, leaders from the Black community. So we know in the Black community, oftentimes the spiritual community is a very important force in how where decisions are discussed. And then we would like to have nephrology providers like social workers, nurse practitioners, registered nurses. Don't want the group to be too big. So we're looking at about, 10 to 13 people, more or less. And the providers, I would love for the providers to be identified as Black or African American, but I'm just looking for people that have experience working with folks. I feel like what I'm getting from the community members and the patients will be fine. The advisory group is going to meet 3 times over the project to discuss and provide guidance, and we'll have discussions and give us feedback on things that need to be incorporated into the existing guide. And this will all be done through Zoom. So we'll be able to have more of a presence. And sometimes working with groups that have been underserved in healthcare, it can be a challenge to connect, make that connection. Phase 2 is actually where the patients become involved. And so looking at about 10 to 13 patients, they would do a Zoom session where they would let me know what did they understand in terms of with regard to their session based upon the revised guide of the advisory group. And then we'll make further revisions based upon the feedback from patients. And then phase 3 involves the actual providers looking for 10 to 12 nephrology providers to see if the newly adapted guide is effective and easy to use, and would they actually use it. And the providers would be a mix, APRNs, which are advanced practice nurse, registered nurses, licensed social workers, RNs, and of course, nephrologists. Next slide, please. The anticipated challenges, of some of which I'm experiencing right now, would be in terms of timelines of the project. With the team members in terms of securing the advisory group, that can be a little bit of a challenge because it is, just because I'm a Black woman doesn't give me license to go into a Black community and just be able to connect. So relationship building is very important. It might be a little bit easier that I'm melanated, but it doesn't give me a guarantee card, if you will. So building those relationships to develop the advisory group. And then also the commitment to the project, seeing it through, life gets in the way. We've had severe disruptions in the past couple of years. So that is a anticipated challenge. And then the group dynamics, I do, whenever you're working with the community, you do have concerns about some people's voices maybe not coming out as much as you would like. So making sure that all of the group members feel that their voices are heard. Next slide, please. So the implications specific to the Black or African American CKD community would be that there's an appreciation in the investment of removing any cultural barriers to participation in this important mode of service delivery, being telehealth, and that patients and their families will view telehealth interactions as more rewarding because they've had a stake in it, so to speak. So in the guide, having this alternative guide, if needed, they had a part of it, and that's something to be proud of. Nephrology providers would engage more confidently if they in care conversations with their patients who identify as Black, if they're kind of getting stuck and really need to have a resource to go to, I should say. And then the findings that can be easily extended to broader populations, as empathy is an essential attribute in healthcare and aligns with improved outcomes. Healthcare is both an innate ability, but also it can be learned, a learned skill. So this is something that is would be very helpful to providers. And, just in general, patients and their families are going to view telehealth interaction as this more rewarding because their preferences and values will be better integrated. And this is going to help to improve health outcomes and reduce mental distress for this population. So with that, I am going to hand it back over to Joanne. Thank you so much.
Thank you so much, Adriana and Liz. We are just so honored that you trust our coalition to help you with the dissemination of this work. The work that you're doing is so important, and we thank the funders as well. We are so honored for the support we receive to create evidence-based solutions to empower people with chronic kidney disease to receive all treatment options from diagnosis through the end of life. These two projects that the coalition is supporting and collaborating, we were able to show that we can pivot during a crisis and to really help patients with chronic kidney disease. We do need more support and collaborations to disseminate all of these evidence-based resources and tools to clinicians, and especially those clinicians working in underserved and under-resourced communities. Like all healthcare centers during COVID, we saw the stress on the workers and on the patients. And kidney care teams are seeking evidence-based tools and resources, especially for their seriously ill patients. As you heard, those end of life conversations and advanced care planning programs need to be made available and need to be accessible to all patients. Our tools and resources help relieve that stress, not only on the workforce, and giving them those skills, but also ultimately for the patients and their families. So, please consider us as you're thinking about funding opportunities. One of the things we think is critical right now, there's policies happening at the CMS, Center for Medicaid Services, that we could really use a policy consultant to help advocate for some of the evidence that needs to, and the policies that need to help support families and kidney patients. We have so many tools and education programs and so much expertise that we'd love to, be able to disseminate this more widely on a national level, and really need help getting the word out. So education marketing consultant to work with those big LDOs to get the CME, the CNE, the social worker trainings happening. And then of course, there's so much more research to do, as you heard from Liz and Adriana, to make sure that our resources are hitting the populations and are being culturally tailored for the populations that need this help. So I want to again thank you so much, the Grantmakers in Aging and Lindsay Goldman and her team for having us here to share our work, and we're really looking forward to a future where we can all come together and continue these great collaborations. So thank you so much.
Thank you, Joanne. And if all of our speakers can turn their videos back on, we'll do some Q&A. So please submit your questions if you're in the audience and would like more information. I already have a couple of questions. First, I'd love to hear if how are you receiving feedback from both patients and providers who are using the tool, and can you give us a sense, even just sort of anecdotally, what you're hearing?
Joanne, do you want to talk a little bit about how George Washington has sponsored the tool and
Oh,
the work
sure.
with that?
Oh, sure. Yes, I thought the question was directed to you, Liz. I'm sorry. So George Washington University has actually is hosting the tool on its website, and so we're offering continuing education credits as well through the National Association for Social Workers, and we are also working with several large dialysis organizations to provide the tool to their social workers as well. And so we're getting feedback through the evaluation tools and through, to get the CE credit, they have to do the pre and post. So we're getting some feedback there as well. So we are getting some collaborations to actually begin to use the tool in a wider group. And then there has been some interest as well for nurses to use the tool as well as social workers. So that's some of the feedback we've been getting.
And if I could just jump in, I think one of the first pieces of feedback we received from and some of the people are using LDO, that means large dialysis organizations, from leadership in the social work departments of I think one or two of the LDOs who went through and kind of took the course. And their feedback to us was that they thought it was appropriate for more early career people. And this is very important to know because we are identifying as more, so we train people and bring them into the workforce and bring them in to these settings. Most nurses and social workers have not had any specific training around care of patients with kidney disease. So the dialysis center is a completely new place for them. They've not really had any training about telehealth, and they've not, unfortunately, though we've all been working so hard, most people get to their jobs with very little training around serious illness care or grief and bereavement. And so the convergence of all three of those kind of deficits leaves people, especially our newer workers, really feeling lost and feeling quite like left out there to dry. So this kind of education is support to them, to keep them in the workforce, to keep them feeling like they're not in moral distress.
Right. So you're seeing it as a tool for retention.
Tool for retention.
And currently the training is asynchronous, right? But, we would love funding to actually do some live sessions, because that, Liz can speak more to this, that role modeling and the practice is what really empowers people to feel they can have these difficult conversations. But I'll let you speak more to that.
Yeah, I mean, I think if we really draw from like social learning theory and the work of Bandura, we know that people intellectually understand what empathy is. They can say that out loud to you. But through years of working with graduate students and doing process recordings with them and working some with, nurses and MSWs in the field, people will tell us they know how to deliver empathy. But when if we record them and watch it together, it's not happening. And so being able, one of the things I think that would be really valuable is to be able to have one-on-one time with people and work with a simulated patient or something like that, where we could actually dialogue back and forth and stop, pause. What are the things that you can do here in these situations? Because I don't know that we can read ourselves, to the end on this. Reading and listening isn't enough. We have to actually practice some of that as well. And so, and I know that just from my background in clinical social worker, that's how we teach people to do that work. So yes, that would be a great next opportunity.
And I just want to tag on in terms of the, different groups, conversation is very nuanced, right? So, I've had people, if I'm walking down the street and I see another person that is Black, we might do a nod. And I think that's so cool. Did you know that person? It's like, no. So, trying to be able to give people the tools to to so where they feel comfortable in terms of being able to pick stuff up if this is not like a second nature kind of thing. And empathy can look like that. How a Black person might describe how they receive empathy might look a little bit different. I'm not suggesting radically different. We're all human, but anything that's going to allow a provider to be able to connect with that patient, to have those very important conversations, is something that should be considered.
Dr. Glenn, can you give us an example of, something that might be sort of subtly different between, working with a white patient through telehealth versus a Black patient?
That's a great question. Sometimes sometimes this is the lingo, how something's phrased. I mean, and not trying to be funny, but my own children know if I'm talking to somebody white versus I'm talking to somebody Black. They just, in terms of how I'm speaking, not I'm not using, poor English or anything. It just shifts. This is a little bit different. So I think in terms of with patients, just some of the lingo might be a little bit different. The fact that we know that the spiritual piece is important. In the United States, we pride ourselves on being individuals and very individualistic care. And in other communities, particularly communities of color, and I know in the Black community, these conversations are had amongst family, having family present with their pastor, their spiritual leader. That is so important. So making sure that piece is even in the conversation, or at least, acknowledged if that is what is, bringing that up. So that might be a little bit different. Like I said, these are subtle things, but these can make a huge difference. In the literature I've been reading, it's the subtleties that show the empathy, that shows that you are really connecting with that person. So not just sympathy, I'm feeling sorry for that person, or I understand. No, I understand and I can appreciate what you're going through, and I'm not minimizing. If a patient's feeling like their care is maybe how they're being guided in a different way, that provider can kind of pick up and address, this is why I've tailored this this conversation for you. Did I answer the question?
Yes, absolutely.
Okay. Thank you.
We are getting to the end of our hour, so I'd love to give the funders on the call an opportunity to give us some final words of wisdom. What would you say to other GIA members or other funders who are interested in exploring this space, either telehealth or end of life, or even, investing in interventions at earlier stages of evidence space?
Peggy, go ahead.
Well, first of all, Rachel, I loved your slide on the progression and the continuum of early stage, middle stage, and more evidence-based models. I thought that was a fantastic slide. And I love the conversation between and the work that was highlighted here. That last piece of information made me think about the importance of examining our own biases. And, as a white woman, I can't pretend to understand the experiences of people in other communities, but I can commit to examining my own biases and assumptions and mitigating them. And so I think that bias is an important part of, and awareness of bias is an important part of empathy as we move forward. So thank you for making me think about that. And thank you both for the work that you're doing. And Lindsay, again, thanks for bringing the funders together to be able to learn from each other and collaborate on these types of important and impactful programs.
Thank you, Peggy. Rachel.
Very quickly, thank you, Lindsay, for the question. I think it's our job as funders to take risks. And I think we need to take risks in investing early in that pre-evidence area. We all as funders demand the evidence base, and yet it's expensive to collect the data. And if we don't fund the data, then you can't build the evidence base. So I think this is an essential piece that needs to be funded. Thank you for your kind words, Peggy. Also, it's important for us to take a risk and invest in serious illness and end of life care. The pandemic has demonstrated how important this is. And it's also important for us to be investing in marginalized and historically oppressed communities as well. I would say if you're interested as a funder in some of this work, one of the best places to learn more is to join the Serious Illness and End of Life Funders Collaborative calls. This is a terrific community. We're very transparent and open about what's happening and about our love of partnerships and collaboration. So please join the next call. Thanks to GIA and to everyone that spoke today.
Thank you so much to all of our speakers. We really appreciate your being here. Thank you to the John A. Hartford Foundation for supporting this webinar. We will be making the presentation available to anyone who wishes to view it later. Please join us for our next webinar on June 15th on accelerating healthy aging through impact investing. Please follow us on social media, and thank you all for being with us today. Please be well.
Thank you.